maintain healthy habits and routine that contribute to good health and take his or her responsibility in his or her own hands. So, guys, that is quite simple. So, maintaining your role in health and hygiene is also equally important. Now, moving to the next. Yeah. Now we have treatment compliance. As important as it is, like meeting a good doctor and getting the right diagnosis and treatment, is something that patients usually do follow is taking the drugs, which is as important for the right treatment. So the few important points are that the patient should keep in mind is that he or she should be punctual for his or her appointments. Will do my best to comply with my doctor's treatment plan, and I will have realistic expectations from my doctor and his or her treatment, and inform and bring to the doctor's notice if it has been difficult to understand any part of the treatment or of the existence of challenges in complying with the treatment. And I will display intent to participate and intelligently in any medical care by actively involving myself in the prescribed do at home activity. And then coming to transparency and honesty. It means that the patient will make a sincere effort to understand his or her therapies, which include the medicines prescribed and their associated adverse effects and other compliances for effective treatment outcomes. And it also says that he or she will not ask for surreptitious bills and false certificates, and or advocate forcefully by unlawful means to provide them with one. And it also says that if the patient is not happy, he or she will inform and discuss with my doctor, and I will report fraud and wrongdoing if he or she feels that there is need to do so. Okay, and now come. It says that I will be respecting the doctors and the medical staff who will be caring and treating me, and I will abide by the hospital and facility rules, and I will bear the agreed expenses of the treatment that is explained to me in advance and pay my bills on time. Okay, so guys, that wraps up all the 17 patient rights and the patient responsibilities. I know it was quite lengthy, but the factual information is equally important and will form the basis for acting effectively in future situations that as we as healthcare professionals might come across. And now we'll be jumping into the interesting bits of our presentation today, and I'll be handing it over to Prakriti, who will be handling the case discussions. So over to you, Prakriti.
Hi everyone, I hope you guys are still here. So I'll be handling the case discussions. We've assembled 6 cases, and so I'll just give you a brief outline of how we'll go about it. So we will show you the case, and we will ask you like the most important bioethical question of that case, and then we encourage you all to raise your hands, and you can unmute and tell us what you feel like. The questions will be kind of yes or no, but we invite you to give a sort of justification for what you feel. And then after that, I will be telling you guys what actually happened in that particular case with respect to the court of that country. And finally, we will do a brief discussion with use of expert opinions. And if you guys still have any questions, you can raise your hands again. And we can, of course, direct those questions to Princy ma'am, who is on call. So let's start with the first case. Okay, so case 1, Miss E.B. is a 28-year-old woman. Since birth, she has been afflicted with severe cerebral palsy and is a quadriplegic. She is now a patient at a public hospital. Miss E.B.'s physical handicaps of palsy and quadriplegia have progressed to the point where she is completely bedridden. So, except for the ability to move a few fingers of one hand and to make slight head and facial movements, she is immobile. She is physically helpless and wholly unable to care for herself. She is entirely dependent upon others for all of her needs. These include feeding, washing, cleaning, toileting, turning, and helping her with elimination and other bodily functions. She cannot stand or sit upright in a wheelchair. She lies flat in bed and must do so for the rest of her life. She also suffers from degenerative and severely crippling arthritis. She is in continual pain. She receives automatic injections with periodic doses of morphine through a tube permanently attached to her chest. These injections relieve some, but not all of her physical pain and discomfort. She is intelligent and very mentally competent. To eat, she must be spoon fed. Because of her previously announced resolve to starve herself, the medical staff fears her weight loss may reach a life threatening level. Her weight seems to hover between 65 and 70 pounds. Accordingly, they inserted a feeding tube against her will. Miss Evie is not terminally ill. She's anticipated to live another 15 to 20 years. Okay. Uh, yeah. So our question here is, should the medical staff force feed Miss Evie? And please tell us what you feel. You can just say yes or no and why you feel that. And if you can't unmute, you can put it in the chat box. Please don't feel shy. Just raise your hand, or worst case, you can put it in the chat box. We want this to be a very interactive discussion.
Hello.
Yeah. Hello.
Yeah, I don't think that the staff should force feed her because I think one of the rights that he had mentioned was that the patient should be willing to get treatment, and if the person herself like decided not to eat, knowing and we know that she is mentally competent, so she knew what the results would be like if she stopped eating, and yet she made a decision. So they shouldn't go against her will to.
Yeah. Okay. Very fair. Does anyone else have any other opinion?
I can I go?
Yeah. Sure.
Yeah, I think considering that the will of not eating food or resolving to starve was made before the patient possibly was ill, I think she should be fed food because it is in the best interest of the patient to be fed food, considering that her health is crippling, though not terminally ill. Even for the medicines to work, I think a basic amount of food should be given to her, considering even her weight is hovering between low ranges. So I think she should be given food, but in case her health improves, and now if she gives another resolve that she does not want to eat food, that can be considered like the absolute thing.
Okay. Also fair. Anyone else?
Can I go?
Okay. Yeah. Sure.
Yeah. So I have an opinion that considering Evie said that she doesn't want to eat anymore. She's kind of starving herself, which is I may not be absolutely correct, but it falls kind of in the passive euthanasia kind of situation where she's refusing treatment or she's refusing food, something which is going to end her life willingly. And since she's in a clinical setting and since she is completely dependent on her doctors or on her caregivers for her basic everyday necessities, I think it is in the under the aegis of the pillar of non-maleficence that the doctors that her healthcare providers have inserted the nasogastric feeding. And I guess they want, even though she is mentally competent, they want her to live. They want her to give her time to maybe reevaluate her decision. So according to me, in my opinion, I think it falls under the aegis of non-maleficence, and I think the decision was not absolutely right. not absolutely wrong also, but it's in a gray area, and obviously it'll also be influenced by the laws of her country, of her state. So in India, euthanasia is illegal, so maybe I don't know about the background of this of the situation, but it may be a factor that the healthcare workers' hands may be tied legally, so they may have to save her even though it's against her wishes. Yeah.
Okay, yeah. Thank you for that. I think some people have said some things in the chat box. Pranali says no. Karan says at least attempts should be made. Simran says the staff should try to make her understand at least once. I think we can do one more minute if anyone else needs to has any other opinion they'd like to speak up.
Can I go?
Yeah, sure.
So, see, she's already, according to the case, she's already 28 years old and she's able to make her own decisions. So, I, as a doctor, would tell her what, she should be doing initially. And if that does not work, I would just give a proper counseling, like, just tell someone else to counsel as well. Because the patient has his or her own rights to make a decision and follow it. We as doctors have no right going against it. And the last thing I would be doing is getting a, written document signed by her so that no future problems happens in the in case if some legal actions come up.
Okay. Anyone else?
Yeah, if I may add a point regarding the patient responsibilities also, when we include the patient also has the responsibility for the treatment compliance. So in case the healthcare provider feels that it is imperative to feed her food that which is very essential for their sustenance, I think they can be given food because even patients have the responsibility for their health.
Yeah. Okay. Okay, thank you guys so much for your opinions. So coming to this question, should the medical staff force feed Miss EP? So broadly, there were two opinions. So one was no, and that falls on the basis that Miss EB has a fundamental right to refuse medical treatment. Therefore, the medical staff cannot force feed her. Um, Otherwise, the other opinion is yes. And the thing is that food is a basic need and not a medical treatment. So, by not force feeding Miss Evie, the medical staff will be helping her commit suicide, which is counter to the interest of the public. So, in balancing Mrs. Evie's right to refuse this treatment against the damage which will be caused to public policy by her suicide, the medical staff must act to prevent suicide. So, Miss EB is trying to starve herself to death, and the state would not want to be a party to the suicide. So, these are broadly the two directions you could have thought about this. Now, I'll tell you what actually happened, the court decision of this case. So, this case came before the country's Court of Appeal, who concluded that if Miss EB is force fed, she will face 15 to 20 years of a painful existence, which is endurable only by this constant administration of morphine. Her condition is irreversible, and there is no cure for her palsy or her arthritis. So, Miss EB would have to be fed, cleaned, turned, bedded, and toileted by others for 15 to 20 years. And although she is alert, bright, sensitive, and perhaps even brave and feisty, she must lie immobile and she is unable to exist except through physical acts of other human beings. Her mind and her spirit may be free to take great flights, but she is imprisoned and she must lay physically helpless. And that makes her subject to a lot of embarrassment and humiliation, which will be created by her helplessness. So the state said that it was not the policy of this state that all and every life must be preserved against the will of the sufferer. Um, they said that it was monstrous for medical practitioners to assert the right to preserve a life that someone else must live, or more accurately, endure for 15 to 20 years. So the Court of Appeal cannot conceive that the policy of the state is to inflict such an ordeal upon anyone. So, as a consequence of her changed condition, it is clear that she has now merely resigned herself to accept an earlier death, if necessary, rather than live by feedings which are forced upon her by this nasogastric tube. So her decision to allow nature to take its course is not the same as deciding to commit suicide, with real parties aiding and abetting it. So Mrs. EB's right to refuse this medical treatment, even of the life-sustaining variety, will entitle her to immediate removal of this nasogastric tube, which was first of all involuntarily inserted into her body. And the hospital and the medical staff are still free to carry out a substantial, if not greater part of their duty, that is to alleviate Mrs. EB's pain and suffering. So what they said was that the right to die, it is an integral part of our right to control our own destiny so long as the right of others are not affected. That right should include the ability to enlist assistance from others, including the medical profession, in making death as painless and quick as possible. So this is basically what the court in question of that country had to say for this case. Later on, when it was discussed by experts, they looked at it in this way. So this case is basically about a patient who is refusing medical treatment. But the first issue that we have to look at in this case is whether provision of nutrition and hydration is it a clinical procedure. So if you look at common standards, it's really not. So if a parent who your parents will give you food and liquids, that is not clinical treatment, right? But when we look at dependent patients who cannot feed themselves, they are forced to be nourished and hydrated. So there are two ways to look at this. Some cases you have a third party like a nurse or your own family member or relative who will be spoon feeding the patient. This is again more like a case where your own mom is feeding you or like a parent is feeding a child. So again, this is not much like a clinical procedure. However, on some occasions, because it is too laborious to sit and feed the patient all the time, we adopt these procedures like inserting lines and tubes, which are invasive. So these can be somewhat called as clinical interventions, but these are adopted more as a convenience and they're not really a clinical necessity. Then finally, we have the third case where the patients have lost swallowing reflex. So here, these interventions that we use are actually a requirement. So here, it kind of becomes a necessary medical treatment. So the thing is, in this case, when it is a clinical treatment, patients should have the right to refuse them. So the same way that people are allowed to refuse chemotherapy or radiotherapy, like in cancer cases, or blood transfusions in liver surgery, they have the exact same right to refuse nutrition and hydration. So the right to refuse any medical treatment is nothing but an elementary right of every individual. When the treatment is offered, the patient must assess the benefits of the treatment as well as the consequences of non-treatment from the perspective of from his own perspective, and that again will include a lot of things, right? The patient's religious beliefs, the patient's own opinions, his or her own life experience. So another conflict that was brought up here is nothing but the right to die. It's obviously a very controversial topic. The thing is that the problem here is that doctors may feel obliged to treat without regard to the patient's wishes. So that is what we saw in this case. Since providing some of these treatments are considered essential to life, it is easy to neglect the rights of the patients at the same time. So in this case, while not providing nutrition and hydration does result in allowing the patient to die, it does not mean they are killing the patient if she has already refused permission for the doctor to rescue her. And even if she had not refused, the non provision of this nutrition and hydration might be justified on the basis that the alternative here was that she would have had a very inevitable, imminent, and prolonged, very painful death. So, extended dying in such cases, as would be achieved by the application of artificial nutrition and hydration, is not considered to be equivalent to saving the patient's life. Okay, so this is what the officials had to say. Let me just check. Okay, so there's a couple of questions in the box. What if a guardian or caretaker is willing to take the responsibility? Princy ma'am, would you like to take up this question?
I just would like to add on to what you have said. In a situation when the patient is at the mercy of others and
Ma'am, I think you are muted.
okay, yeah, am I audible now?
Yeah, you are.
Yeah, okay. So when you see this case, what you have to note first and foremost is that it's a question of artificial nutrition hydration, and also the there should have been a, if it was, there was an advanced directive, that is a new thing that has come into the, if the patient has discussed about euthanasia beforehand, this is not that part of a question. Those are also things that come up. So if you want to talk about do not resuscitate, you can have a DNR form filled. You can have a advanced directive, a living will can be given. These things are now gaining interest in India, not before, but now these things are coming, DNR. But you must see the beautiful Supreme Court ruling and Y.V. Chandrachud's decision that no, there is no question of euthanasia, in any case. And active, impossible, even passive is only with a little care, and that should be taken as in when it is needed. It should be laid up to the board. Okay, now in this case, we are talking of ANH. You have to see whether sometimes, artificial nutrition hydration, about it, it's not natural. If there is no food, person will die. But this is over, and the patient, even if you stop artificial nutrition and hydration, it's acceptable at times. Okay, so this is just one thing that I needed to draw your attention to, and I hope you have. This is the court decision that she has told you, and this is a court decision having laws from another country. It's not an indigenized one. So we have to see every case as it is with our laws. So that is one point also that has to be noted. So we have to be always updated. Yeah, that's all about it. You have done a good job. And the first speaker, the boy, Sohail, he has also taken a good view into the patient rights, how it came about, the rights of the patient, and the Charter of Bill of Rights, the 17 points in our bill that by the Indian government. That is what was done. That was very well. And Prakriti took us through this case discussion. That was very nice. Thank you so much for doing such a wonderful job. And I'm sure you all listeners, in your minds, you can take varied angles of the same thing. And when you see a case such as this or any other, sometimes we even miss the ethical problem as a whole. So listening to such discussions, you can hone your talents and find out what are the ethical problems. Sometimes you may have one or two problems, and sometimes it will be one principle vying with another, conflicting. So if you have to do this, then you are doing another. So these kind of aspects do come into the room. So this first case was a good one. Thank you. Let's go ahead into the next.
Thank you so much, ma'am.
Thank you so much, ma'am. Thank you so much.
Yeah. Okay. So we still have 5 more cases, but we'll try to go just a little faster. So coming to the next case.
Yes.
Okay. So coming to case 2, we have Mr. HS. His hand was badly injured in a motor car accident, and he was taken to the local hospital. Dr. M, a physician and surgeon duly qualified to practice, was called to the hospital. Mr. A, just being a stranger and unacquainted with Dr. M, asked the doctor to fix his hand, but not to cut it off, as he wanted to have it looked after in his home city. Later on, in the operating room, Mr. H has repeated his request that he did not want his hand cut off. The doctor, being more concerned with relieving the patient's suffering, replied that he would be governed by the conditions found when the anesthetic was administered. Mr. H has said nothing in reply. As the hand was covered by an old piece of cloth and it was necessary to administer an anesthetic before doing anything, the doctor was not yet in a position to advise what should be done. Upon examination, the doctor decided an operation was necessary to amputate the hand. Dr. M said that the wounds indicated that surgery was necessary, as the condition of the hand was such that delay would mean blood poisoning, putting the patient's life at risk. The two other attending physicians supported this decision. So coming to the question at hand, should Dr. M have amputated Mr. H's hand under these circumstances? So you guys can put in the chat box or unmute and tell us what you feel.
I think the doctor, although the patient declined to get an amputated and had the right to choose an alternative treatment and seek a second opinion, but the thing at hand is when the doctor examined, he was of the opinion, concurring with the other two physicians, that there would be blood poisoning that could endanger the actual life of the patient. So I think autonomy here takes here autonomy can be superseded by the principle of beneficence, as the patient's life was even more important than saving her hand. So I think it was the right decision.
Okay, yes. Very true. Anyone else? Okay, some people are saying yes in the chat box. Yes, as it would save the life of the patient. Simran also says yes. Anyone else? Okay, we'll go ahead. So again, we could the answer to this question again could be yes or no. If you said yes, it was probably because Dr. M had to amputate Mr. H's hand. If the surgeon had not amputated the hand, the patient would have been at risk of blood poisoning, which would obviously threaten his life. So in any case, the hand would not have been saved. So that's why you could say yes. You could also say no, because amputation is an irreversible treatment. And Mr. HS was clear in his instruction at first that he asked explicitly not to cut off his hand. Right? So what actually happened? What was the court decision in this case? So this case actually it came before the Supreme Court of the state. The court concluded that the operation had been necessary and it was performed in a satisfactory manner. And the damage and loss and the cost of an artificial hand are the results of this accident, and it is the result of the accident and not the operation, basically. So Mr. HS is entitled to the damages because of the trespass to his person. So he is entitled to some of the damages. The thing is here that Mr. HS is an immigrant without much education in the local language and probably of not more than average intelligence. So when he did not reply or make any objections to the doctor's statement, Dr. M took it for granted that he would be governed by conditions as he found them, and that he had full power to go ahead and perform an operation if he found it necessary. On the other hand, Mr. HS probably did not understand what the doctor meant. If he had, he would most likely have refused the operation. So, under these circumstances, the court actually said that Dr. M should have provided a more detailed explanation and tried to get Mr. HS to consent to an operation if necessary. Okay, so in this case, what are we seeing? We are seeing treatment despite a patient's opinion. So, obviously, the patient has the right to refuse the medical treatment offered to him because it is a part of one's basic autonomy. We all know that pillar. So, as far as possible, based on the clear and the information provided the patient, he should be allowed to agree or refuse. But there were certain problems if you saw in this case. First of all, the surgeon heard that the patient was refusing to go through with the amputation, and what he should have done at least was check the hand before giving the anesthesia. The doctor simply said that he would do whatever he thought necessary when he got around to examining the man's hand. So, if he had first observed the nature of the injury and then sought consent from the patient with the benefit of the information that he would have gained if he had done the inspection, then the patient's view might have been different and there might have been no problem at all with carrying out this procedure. So, when this procedure is possible, disabling the patient by not letting them give informed consent to surgical intervention, it's very bad to do this. It's actually bad practice. And if the surgeon, upon inspection, is persuaded that okay, you have to do an amputation to save the life of the patient, he can still not really override the refusal of the patient to undergo the procedure as long as the patient is competent to refuse. So if he felt that if this is a case of incompetence, then the surgeon should err on the side of life. But if it's a case of disagreement between the view of the surgeon and the view of the patient as to what an acceptable treatment is, the views of the patient should technically prevail. So that's what the experts had to say about this. Does anyone have any questions? And Princy ma'am, would you like to? Okay. Arpit has a question. Can competence supersede the life in question? Princy ma'am, would you like to take this?
Yes, yes, yes. In fact, I was thinking on these lines. When you see in this condition, this case, it is very clear that amputation or septicemia, any of them, the patient will lose his life or he can have a life without an arm. So this is a clear-cut case where the benefit and the harm is in juxtaposition, and you have to opt for any one of this. The only thing that went wrong in this study was this case was that the information was not delivered to the patient, maybe because the doctor thought that he's a migrant and not aware of the language and not literate enough. He didn't go on to that aspect. So if you were to do that, you would be more complacent. Now, when you're looking at these 2 points, what was the question that was raised? They had asked about 2 points, no?
Can competence supersede the life question?
Competence.
Yeah.
Competence of the patient. That is
to
the
make a decision.
Yes. It is called as the capacity to consent. Is he competent enough to consent? Is he understanding the problems in its reality? This is another point. And another aspect is the saving of the life. So competence of the patient, like now we are in COVID times. For us, any vaccine that comes on the market would do. Okay, because we are totally at a loss. We have nothing else to grab at, and any straw would do. That is the situation. So you are competency of the patient is a point, because whatever said and done, whether he's competent, understanding, educated, illiterate, unaware of his things, we should not negate that person as a human being. That is why we are looking at competency, and this competency to testimony, competency to consent, comes from the fact of that he is a human being, he has his dignity, and dignity is what we give to the person, to the other person, respecting the other person, that we have to do, not that person. So we have to you have to understand and give due regard to competency, but not at the cost of life, but consent such as this is necessary. As far as possible, possible to try and get consent. In fact, the only thing that was done is we have not looked. From these cases that you see, we have come to the fact that we make individualized, customized according to the operation that is needed. You have taken initial consent for a laparotomy and a following second consent. If we look in the stomach and we see that there is an ectopic and it is endangering to your life, can we remove it? We can tell at that time. Okay, so you have to inform it to the patient and take a complete consent even for a procedure that could be done. So that is safe, because otherwise you will do laparotomy trying to find out exploratory laparotomy to see what is wrong with the patient, and then you come back and realize there's something that is immediately dangerous, and you can do it at this one go, but you have not taken consent of the patient. Then you have to go, patient has to go through the rigmarole all over again, because you have to take a consent and then only go on to the next procedure. So these are things that we have learned from such cases, classical cases. There's another case where a lady had a dissecting aneurysm of the abdominal aorta, and just for the fact, that she didn't want her side of the abdomen cut and have a scar, she refused to the operation of dissecting aneurysm of the aorta, which is a 50% chance only for her living. And still the doctor took the chance with the husband in deception, deceived her, and they told her doing something, and they did that, and the patient survived, and she still went and sued the doctor for having done this in a deceptive manner. And the doctor was just reprimanded because he took it out of the life, for the life of the patient, So consent is very important. And, you cannot benefit a person if you have not considered his autonomy. This is another moral tenet that you have to do. If you're doing according to my wish, I will be happy with the result. But even if the result is good and it is against my wishes, it will not be acceptable. You see? And you cannot just make a consent yes or no. You must talk to the patient and different times in different situations and ask for, try to get the consent, for which a chief surgeon is the one who is doing the operation. He's the one responsible, but he can have his team, the junior doctors, nurses, and the MSWs. All of them can work to help and counsel the patient, and at last get a consent if there is time, that is. So competency does trump over the life of the patient also. It's not always, that's why that is the gray area that is always there, So we try to get the patient's consent and go ahead and do things. That would be a better way. And we learned it in a different way. If you see in NABH, you see in the hospitals, we make consent forms that are, layered consent forms, and they are customized to that particular surgery or etc. I hope.
Ma'am, sorry to interrupt, but there's another question. If the patient unfortunately loses his life due to sepsis after the decision of not to amputate by the surgeon, would this be medical negligence?
It can be proven beyond. This is a proven beyond doubt that if you do not amputate a gangrenous or such a thing, it will lead to. It is known, and it is definite leading to death because of septicemia. This is a definitely proven thing. So here it can be construed, but wherever you take a consent and the patient and the bystander all refuse, document it there and then, time dash. You have taken the question, you have asked them all the things, you have informed them. We call it as a valid informed consent. You always heard the word, not just consent. We give them information and then help them to make their decision. That is why it is called informed consent. But today we have another term that is called as valid informed consent. That is to say, valid meaning telling the patient of the less than 1-2% risk is not necessary. But here, to answer the question, the patient dies and the septicemia was not told. It's a matter of your death or your life have to be clearly told to the patient. And in absence of that, if the patient still agrees and you have documented it, you are safe. But in this case, because it's a well-known complication, only things that are unexpected, there you can have a clarity for doubt.
Thank you so much, ma'am. I hope everyone got some clarity on that case. We'll move on to the next one. Okay, so here we have a 43-year-old patient who has had schizophrenia since he was 20. At the moment, he has a chronic form of schizophrenia, which is marked by chronic deficits, dominant negative symptoms, and the constant presence of delusions. The patient's condition is known from the reports by the patient's mother because he refuses to consult a doctor. He has never been aggressive to others and has never met the criteria for compulsory hospitalization. Recently, his mother has noticed a worsening in his condition, including intensified positive symptoms that impair his social functioning. She asked for compulsory treatment. The psychiatrist, acting in the best interest of the patient, prescribed risperidone in liquid form to be added to his soup by the mother. This treatment has had a good result. The patient began walking his dog for the first time in 6 years. So, coming to the question, should the psychiatrist have been allowed to collaborate with the mother by assisting her in administering medication to the patient without his knowledge? You can unmute and tell us or put it in the chat box again.
Yeah, I think cases, particularly pertaining to mental illnesses, are slightly more complicated because, as in this case, the person was unwilling to get treatment. And if the mother thinks that treatment was required, then the doctor should have helped her and give the medicine to the patient. And maybe for better understanding of the patient's case, he could have contacted other people close to the patient to make sure that the mother's intentions were not, um, they weren't actually harming him more. So what I think it was for the benefit of the patient that they administered the medication.
Yeah, okay, very fair. Anyone else have any opinion? Okay, so we'll move on. So, coming to this question, again, there are two answers, possible answers. One could have been yes, because the benefit to the patient's health, which we saw, justified this action. And the other could have been no. It is the patient and only the patient who should be treated by the psychiatrist, and the psychiatrist has sole operative responsibility. The doctor is not permitted to cooperate in depriving the patient of his independence. Okay. It could also have, okay, so coming to the court decision, in this case, in principle, a patient shall be entitled to have access to the information concerning his own health. So, treating a patient without his knowledge is not usually considered to be ethical. Moreover, prescribing a medication to a patient without examining her or him is not acceptable and implies legal responsibility if there are some serious side effects seen. Treatment without examination and the full knowledge of the patient is already a wrong premise, providing it without the patient having given the benefit to know of his condition. And to be an active participant in his treatment violates his autonomy, no matter how well meaning the doctor and the patient's mother are. So, there might be a number of situations where the solution can be considered. Like if the patient is not competent, or if the patient lives, for example, in a very remote area and there is no doctor around, which can be seen in many developing countries. The right of the patient to be informed may be subject to some restrictions in order to prevent like serious harm to his health. However, this privilege is open to great abuse, and it should only be used in very extreme circumstances. So, um, so what we see in this case is treatment through a third party. So when we look at a patient, his dignity and rights can be expressed in several ways. And these include confidentiality of medical information, as well as inclusion of the patient in decisions regarding the medical care and others. Now, sometimes patients are not mentally competent and maybe they can't take part in the therapeutic processes. So, this whole question of the third party comes up. Now, in this above situation, maybe the consent was not specifically required because the competence of the patient to decide for himself was not clear. And in such states, he might not, in the state, he might not have been able to make a reasonable decision about his treatment. But the problem here is that the doctor has not assessed the patient firsthand. And that shows us that he assumed that the man's condition was such that he was not competent enough to ask for or to decline the treatment. So if he thought that the patient was incompetent, the doctor should have at least sought permission to compulsorily examine the patient. If he thought the patient was competent, then the doctor's action to providing compulsory treatment would have actually been against the law. And the involvement of the mother as well, the experts said that it was very unprofessional. So this is what they had to say about this case. Does anyone have any questions regarding this case? Princy ma'am, would you like to add anything to?
Hello. Hello. Actually, I had a doubt that in this case, the patient was not competent to take the right decision for himself. So, what should have been done in a better condition by the doctor?
Yeah. Oh, very good. You all are thinking. Your thinking caps are on. First and foremost, I would like to inform you, you are a doctor. To whom does your, to whom do you owe? You owe to your patient. You owe your liability to your patient. And in this case, they are doing deceptive therapy where the patient has not even come and not even been examined. This is, you didn't even give him the chance. He refuses to come to a doctor, but maybe just in case he had come to the doctor, he would have been confident and he would have come. Whenever we talk, you say that this case is difficult. Supposing it was any other case other than psychiatric case, you would have thought that it was easy. But being psychiatric case, he cannot be competent enough to give a decision of his own, of his autonomy. That is what we are concerned about. But friends, every psychiatric patient at all times is not without competency. If he has insight at different stages of his disease, he will be having different levels of insight, and that makes him competent to make his own decisions. And that is why you cannot just say just because he has some mental illness, he is not competent. He has to be such a person's competency or testimony capacity should be tried by a panelist, a group of panel members. They will decide on his testimony capacity if needed. But yes, this kind of therapy where you deceive the patient is not acceptable, one. And another thing is you cannot treat a patient without having examined. No telephonic conversation about a drug to be given on this condition. You have to actually see, you have to have liability, and otherwise the competency is not right.
Thank you, ma'am. Is there any other question for this case? Okay, so we move on to our last case. Okay, so in March of 1987, Mrs. M was diagnosed with medullary thyroid carcinoma, a genetically transferable disease. Her physicians did not inform her or her children of the possibility they may have inherited this genetic condition and therefore may be at risk of developing the lethal disease. Needless to say, Mrs. M's physicians also did not tell her or her children they should be tested for medullary thyroid carcinoma. Since they were ignorant of the potential impact of their mother's disease, Mrs. M's children did not undergo any testing. 3 years later, Mrs. M's adult daughter, Mrs. H, learned that she also had medullary thyroid carcinoma. It is likely that had she been tested when her mother was diagnosed, she would have taken preventative action and her condition, more likely than not, would have been curable. Mrs. H suffers from advanced medullary thyroid carcinoma and its various debilitating side effects. So coming to the question, does a physician have a duty of care to warn a patient's children of the genetically transferable nature of the condition for which the patient is being treated? So you can unmute and tell me, or you can put in the chat box. Yeah, tell me. Anushka?
Yes, I think this one definitely there is the physician needs to be transparent with the patients, and as we saw in this case itself, like the child, Mrs. H, suffered because the doctor didn't inform her of the illness, and thus led her, which could have been prevented. So he should have been transparent and told and informed the patient.
Yeah, okay. Does anyone have any other opinion?
Hello, am I audible?
Yes.
Okay, yeah. So I also have I would like to point out the concept of prospective counseling also, which should be with it should have been adhered by the physician, because it is just not affecting the child of the lady itself, but also affecting the the public at large. Because although genetic diseases are not infectious, it can have an impact on the society further. So I think the physician should have told the patient, so that they could have adopted different strategies to ward off the maybe not completely the risk, but reduce the risk, so that the child to be born could have been saved.
Yeah, okay. Very fair. Does anyone else have anything to say? Okay. So yeah. So coming to this question, again, some people can say yes and some people can say no. If you said yes, it's probably because When information can be beneficial to third parties and the physician knows of the existence of those third parties, the physician's obligation extends to those third parties even at the price of disclosing confidential medical information. The prevailing standard of care was obviously developed for the benefit of the patient's children who fall within the sphere of foreseeable risk as well as for the patient. So, therefore, the physician has a duty of care with respect to Mrs. M's children. If he said no, it's probably because Mrs. M's physician had a duty of care to warn Mrs. M of the genetically transferable nature of her disease and to explain to her the importance of testing her children for medullary thyroid carcinoma. But that duty does not extend to warning Mrs. M's children. Moreover, requiring a physician to seek out and warn various members of a patient's family would often be difficult or impractical and would place a heavy burden upon the physician. Okay, so coming to what happened, the court decision. So the case again came before the Supreme Court. The court concluded that when the prevailing standard of care creates a duty that is obviously for the benefit of certain identified third parties, and the physician knows of the existence of these third parties, the physician's duty will extend to these third parties as well. However, this warning should be addressed to the patient. The physician is not required to personally warn the patient's children about the disease. Moreover, in most instances, a physician is prohibited from disclosing a patient's medical condition to others, except with the patient's permission. Thus, in any circumstances in which a physician has a duty to provide a warning regarding a genetically transferable disease, that duty will be satisfied by warning the patient. In this case, the physician kind of failed in his duty to warn his patient that a lethal disease for which he was treating her was genetically transferable and that the patient's children were at risk of developing the disease. But the court reversed the dismissal of this negligence claim and it was actually sent for further proceedings. Okay, so what are we seeing here? So a physician obviously has an obligation to his patient and he must act in the best interest of his patient at all times. So at the same time, we also know that he has an obligation to not disclose confidential information relating to his patient to third parties, even if they are family members. But also, like we all already know that this right of confidentiality is not absolute. So there are instances when doctors are freed from confidentiality, right? For example, when we have control of infectious diseases like diphtheria and threats to public health, like diagnose epilepsy, say in a public service vehicle driver. So in these cases, yeah, the doctor has an obligation to inform the relevant authorities when personal privacy should be sacrificed for the sake of public well-being. Now, another case arises. Sometimes the threat posed by this clinical information is perhaps only to one. But here we need to look at how serious the threat is. So obviously, very serious threats, even if it's just to one person, they of course by the disclosure of the patient's health information. Now, another thing is what we're looking at is genetic data. And we look at genetic data a little more differently. It's a bit more of a gray area because, again, genetic information is also information of persons and the persons related to them. So, the question of whether these persons should be informed about genetic test results of their patients' relatives is therefore less clear than usual diagnostic situations. And finally, there are other two more parameters which we have to take into consideration. So that is the seriousness of the threat and the imminence of a threat. So sometimes the threat can be of a serious nature but not imminent. And it can also be imminent but not serious. So in these cases, voluntary disclosure by the doctor is appropriate. But when the case is both serious and imminent, then involuntary disclosure should ideally be done. And this case that we just discussed, it appears to be of the latter kind, that is both serious and imminent. Therefore, what should have been done was early intervention, which would have enabled avoidance of a serious and imminent health problem. So that is what the experts had to say. Are there any questions about this case? Okay, Princy ma'am, would you like to add anything to this case?
I just would like to say that with the advancement of technology, day by day we are coming to know more and more things like genetic diseases and their incidence and so this kind of prescriptive genetic testing followed by genetic counseling is quite mandatory. And in this case, as we saw, this Mrs. H, the daughter of Mrs. M, who had the medullary thyroid cancer, she would have been saved from a imminent cause of death, like, So that is the reason why we have to consider all these aspects. So your patient directly, your liability as a doctor is to the patient in front of you. As also, now we call a doctor-patient relationship as a tripartite relationship. That is three persons, doctor, patient, and another, that is the society at large. So doctor is accountable also. And that is why we have to consider these cases where doctors can tell. You talked about notifiable diseases. Yes. And today also there is an aspect of confidentiality that came up in COVID cases. Those who are diagnosed with COVID and positive, their name should not be informed. There was a big rush on all those. These are all things to maintain the greater good. So when we look at the utilitarian outlook of understanding the good for the people, we should do maximum good for the maximum number. So when we can, before there was a time when we couldn't do genetic testing and inform, maybe the female fetuses only would be getting a particular disease. So, you can allow them for abortion, knowing that so that they can miss that inheritable risk of a disease. So these are aspects that should be considered as the advances in technology are increasing. We are having better tools in our hand, show and reduce suffering and injury to mankind. So this is a typical case of genetic testing, genetic counseling, prenatal diagnostics, all these are coming in the fray to reduce suffering to mankind. So these sort of issues do crop up, but I'm sure you have understood very well from these cases, 6 cases that we've taken now. I'm sure you've come to a wider understanding of how a duty of the doctor is.
Thank you so much, ma'am. And also thank you guys for interacting so much and giving us your opinions. We're done with the case discussion part and we'll be moving on to the last segment. I'll hand it over to Sumaiya.
Hi everyone, can you hear me? Am I audible?
Yes, you are.
Thank you. So we're really sorry for being over time, but this is our last section. It's going to be really short. It's going to be interesting. And it's basically like a quiz to see if you can see a situation and assess what kind of a patient right is being violated or being highlighted. So put on your thinking caps, be on edge. Now, the next section, I have 3 short clips for you. And I will tell you the context of the case, the video before I show you the video. And then after that, you have to tell me what patient right is being highlighted throughout the clip. So, keep your chat boxes ready and, answer fast. The first video, which we're going to show, is a patient that has come into the hospital. And it's a very unusual case because initially the patient, he was a man. He was thought to have a hysterical pregnancy because the wife was also pregnant. But it turns out he took a pregnancy test and it was positive, and his abdomen was distended, but it was not ascites. So it turns out that he actually had a big teratoma, and an adult man having a teratoma was very rare. So, there was a lot of excitement and confusion among the interns, the residents who got the case, and everybody was really excited to have seen such a rare case. So we're going to show you the clip now.
Hands off. What is going on in here? Everybody, out!
We already
out! Mr. Herman is a patient, a surgical patient, who's sick and embarrassed and tired of being stared at. You two, this isn't a zoo! Out! 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 If all of you want to point and whisper and stare at me, knock yourselves out. Look at Meredith. Isn't she sad and pathetic and heartbroken? Maybe she's gone mental. Maybe I have. But leave Mr. Herman alone. You should be ashamed of yourself.
Okay, so which patient right is being highlighted in the clip, which was initially being violated? You can put it in the chat box. You can unmute yourself if you want to. Confidentiality, yes, we have human dignity and privacy. Right, so you get the gist. Basically, all the attention, all the, doctors and the crowd was making the patient uncomfortable, but he wasn't saying anything because, he was trying to cooperate. But yes, so the right patient right, which was being highlighted and violated, was the right to human dignity and privacy. So good, you guys did pay attention. Okay, moving on quickly to the next clip. The next clip, the background is that the hospital has a patient who has come in, the patient is basically a prisoner, and the prisoner is on death row. So he is he's supposed to have his execution in a few weeks. And this patient, he's committed crimes, like he's a murderer, he's a serial killer, and he's come because someone stabbed him in the back. And the treating doctor and the resident, they're having a conversation about giving him painkillers. So we will look at the clip now.
Mr. Dunn is still in a huge amount of pain. Can I give him more morphine, or will that cause problems with his neuro exams?
Mr. Dunn has had enough morphine.
Right, but he's got a foreign body lodged in his spine. It's inhumane.
Oh, killing people is inhumane. Denying painkillers is a judgment call.
Derek, what's wrong with you?
I watch people die all the time. I go to families and I tell them their world has been ripped apart all the time. And I fight like a dog to make sure I don't have to deliver that message. And I lose that fight all the time. And somebody like that comes along and simply throws it away. Life. Then he's got the nerve to tell me that he and I are two sides of the same coin.
You're not.
He doesn't need morphine.
So again, same question. Which patient right is being highlighted in the clip? Non-discrimination. Anyone else? Although yes, that is the right answer. But just to sum it up, if you didn't get it, the doctor, the treating doctor, he was unwilling to give him morphine as a painkiller because he had a prejudice against the patient who was a convicted serial killer. And he had made a comment earlier about comparing doctors to serial killers, because he said something like, when we meet people, when doctors and like the killers, they meet people, they're alive. But in the end, it's not that. And that comment, which was actually a very controversial comment to make, really, pissed the doctor off. And so, he was prejudiced against it. Right to treatment, yes, basically it's more of like right to non-discrimination that was said. Because, doctors don't have a choice to discriminate on the basis of the personality of the patient. They have to look at all patients equally regardless of sex, gender, caste, creed, and even if they're convicted murderers or not. So I hope that is clear. If there are any questions, you can put them in the chat box. Okay, we move on to the last clip.
Let's add a CPK to his next blood draw. What was his last name?
Okay, I'm sorry. I will give you a short background before I start the next clip. So the next clip is a patient who's 19 years old who's come in after having an accident, and he's had an aortic dissection, and that's what they have to repair it. But what actually they find out is that he has a pendant, like the ones you have when you're allergic or something, they put it on you so that if you're found in an accident, they know about it. So the pendant says that he's a Jehovah's Witness. And for those of you who don't know what Jehovah's Witness is basically it's a kind of a religion, a kind of cult, where one of the beliefs of the people who follow this is that they don't allow blood transfusion. They don't allow someone else's blood to be given to them, and that's a legit thing. So the next clip, we see a patient who is a Jehovah's Witness, and again the physician and the intern are having a discussion about this because he needs a surgery and that requires blood transfusion.
4. The guy's on fumes.
Try and stimulate blood production by giving EPO.
Or we could give him blood and cut out the middleman.
We can also give IV iron dextrin.
Thanks, Bob.
We can give him iron? How is that logical? We can give him the components of blood, just not blood?
We have to respect his wishes.
What wishes? He can't tell us anything. His friend didn't even know that he was a Jehovah's Witness.
Yeah, it's not the kind of thing you talk about at the skate park.
I'm just saying he's 19. How can he even know what he believes? When I was 19, I was a completely different person than I am now. I wanted to be a radiologist.
Wow. I feel like I'm seeing a whole new you. Start his EPO and keep a close eye on his crib.
Right away, doctor. So you're fine with this? No, he could die. You're fine.
It doesn't matter what I think. He had an alert, it was very clear, no blood. I don't get to have an opinion about it, and neither do you.
So which right do you think is being highlighted in this clip? His life is on the line, but he is, he's unwilling to take a blood transfusion to save it. Yes, I think everyone on the thing is correct. Autonomy, because that's the pillar of bioethics, which is being upheld here. And treating, refusing treatment, alternative treatment, exactly, it's the same, comes under the same umbrella. So, like the doctor in the clip said, we're not allowed to have an opinion about the patient's beliefs. And the patient does have the right to refuse treatment. There's something called against medical advice, which is a report that people give out when patients want to get discharged or they want to refuse a certain kind of treatment, which we know is, the doctors know is the right way to go about them, but they don't want to continue with the treatment. Yes, that is a question which I would want Princy ma'am to take up. There's a question which says, but if he died because of that, who will be responsible? Ma'am, could you take that up?
Yeah. If the a man died in surgery without the blood and taking dextrin, it won't be a case of negligence because due regard has been taken and it has been documented that as the pendant says, they have maintained his autonomy. That is what is to be considered. So that won't be taken. But you must understand some extreme events such as this help us to take extreme measures also, that is also a thing for innovation. To take up the cause of Jehovah's Witness and they are not taking blood transfusion, there are institutes that have autologous transfusion. So the blood from the patient itself will be taken at different times. If you have that, you don't have paucity of time, you have a month or so, you can do this kind of thing and give the patient the his own blood, so that doesn't go against his beliefs, and that can be done. Okay, there are also you can do operations on this patient, even if there was a bystander, you can take a consent of the family, and he's at this cusp age, so he's above 18, so he's he can give consent, but it is an emergency, right? So that's the point that is to be noted in this case also. And as you're an adult, your beliefs should be upheld, but you can always change. There are people who do change when there are times such as this, and you need to actually talk to the patient, inform them, counsel them, and sometimes you may have to talk it out with the close family too, with their permission, with the patient's permission, of course. So these are aspects to be considered. And of course, autonomy. You can benefit a patient only when you also uphold his autonomy, right? We had seen in the other cases that were taken before. And I'm sure it was a really wonderful hour-long experience where we went through the patient charter of rights, the charter of patient rights, all the 17 points we remembered. Then Sohail took us through that, and then we saw how Prakriti took us through the various case discussions, very dissecting cases. We took up 3 of them, and now we closed with Samriti. She has taken beautifully these 3 clips, and you all have answered well. It's wonderful to have you youngsters doing a great job. I'm sure the horizon is looking good. And as we say, Ali Metnikov has said, we need to prepare those doctors we would like to see when we are sick. So I think that is going to come true with youngsters like y'all taking up the cudgels in this world of bioethics. Thank you. Thank you for a very good and informative expo on patient rights. Just can't wait for tomorrow, guys.
Thank you so much, ma'am, for staying with us throughout. I know we went a little overboard on the time, but thank you for making time to come, and thank you to all the participants who took our time and attended and also interacted. I mean, the session was interesting for us as well because of all your inputs. And I think that's it. We can end it now. We will send the poster van form so that you can fill it. That's what makes you eligible for the participation. Sorry, the certificates. That's pretty much it. Masa.
Let's take a picture, Sumaiya.
Yes, let's. Can we have all the videos on for a few seconds that we can take a group photo? The poster van form link is sent on the chat, so please make sure you fill it. We have poster van for today and as well as tomorrow. Any more videos on? It'll just be like a 5-second thing. Okay, let's go. Everyone smile. Yeah, we're done. Great, thank you so much. Thank you again. We will see you tomorrow at 6 again for the second part of today's session, which should be on patient safety basically tomorrow. It will be the same format. We'll also have clips and case discussions. So we'll see you there. Thank you so much.
For those of you who aren't members of Rotaract Club, the Caduceus, I have sent the membership form on the chat box. So feel free to fill it if you think this is something that you like and you want to attend more events from the other avenues. You can reach out to us for any queries as well.
Okay, so we'll wait for a few more minutes for you to fill the forms and then end the meeting. If you still have any questions regarding the event, you can drop them in the chat box. We can get back to you.
You'll have ideas for future events that you all would have, also leave it in your chat box so that we can work on those.
Thank you, Simran. Thank you, Arpit.
Thank you, Arpit. Thank you for always coming to our events. Anusha, you want to end?
Yeah.